Cardiovascular disease strikes in every nation around the world. From sudden cardiac arrest to the disabling effects of acute coronary syndromes and acute ischemic stroke, cardiovascular disease remains a leading cause of disability and death in many parts of the world. Understanding and activating the systems of care developed by the American Heart Association can help improve survival rates and may even prevent cardiac arrest. You play a pivotal role in providing high-quality cardiovascular care. What you do matters. What you learn can save lives. Welcome to the American Heart Association's Advanced Cardiovascular Life Support Science Overview video. In this video, you'll be presented with the most recent recommendations on cardiovascular care based on the latest scientific studies. In the next few minutes, we'll outline the changes in the 2010 American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care. These guidelines were produced after an exhaustive review of thousands of peer-reviewed publications. We will also review several core recommendations from the 2005 guidelines that continue to be emphasized. We'll approach these changes systematically by first reviewing changes to basic life support, or the BLS guidelines, followed by the newest recommendations for advanced cardiovascular life support, or the ACLS guidelines. Let's begin. The steps in the BLS survey for healthcare providers have changed. Instead of the familiar steps of A, B, C, D, where clearing the airway and breathing come before chest compressions now take priority for the unresponsive patient with cardiac arrest. The guidelines now recommend delivering chest compressions before clearing the airway and giving ventilations. The American Heart Association removed look, listen, and feel for breathing and give 2 rescue breaths from the initial assessment entirely. So the BLS survey now includes these 4 steps. Step 1. Check for responsiveness. Tap and shout, "Are you all right?" Then scan the chest for movement. Here you're looking for absent or abnormal breathing. This can be no breathing or only gasping. If the patient is unresponsive, move to Step 2. Activate the emergency response system and get an AED. Step 3. Circulation. Check the carotid pulse. If you cannot feel a pulse within 10 seconds, start CPR by giving cycles of 30 chest compressions followed by 2 ventilations. Do not spend more than 10 seconds checking for a pulse. Step 4. Defibrillation. As soon as possible, attach an AED or defibrillator, and if indicated, deliver a shock. However, if you determine that the patient is not breathing normally but has a pulse, bypass chest compressions and support the patient with rescue breathing, delivering 1 breath every 5 to 6 seconds. Why was it necessary to change these familiar steps? When an adult with sudden cardiac arrest has ventricular fibrillation or pulseless ventricular tachycardia, the heart is quivering but not effectively pumping blood to vital organs. These patients have a much higher survival rate if they receive immediate chest compressions and early defibrillation. The ABCD sequence often delayed chest compressions as the healthcare provider tried to open the airway and deliver ventilations. By changing the sequence and giving chest compressions first, more patients may achieve return of spontaneous circulation, or ROSC. However, there are cases where healthcare providers should tailor the sequence of rescue actions to fit the most likely cause of arrest. This is true for cases involving drowning or other instances where hypoxia is the likely cause of the cardiac arrest. The American Heart Association continues to place a strong emphasis on high-quality CPR in the 2010 guidelines. This is indicated by a rate of at least 100 chest compressions per minute, a compression depth of at least 2 inches in adults, allowing complete chest recoil after each compression, minimizing interruptions in compressions, switching providers about every 2 minutes to avoid fatigue, and avoiding excessive ventilations. The recommendations continue in the new guidelines because scientific studies continue to link high-quality CPR to ROSC. High-quality chest compressions maintain blood flow to vital organs, especially the heart. One way to measure the effectiveness of chest compressions is with coronary perfusion pressure. Coronary perfusion pressure during CPR must reach 10 millimeters of mercury to potentially achieve ROSC. As chest compressions begin, it takes several compressions to raise the coronary perfusion pressure to a level adequate to supply blood to the heart. The higher the coronary perfusion pressure during CPR, the better the survival rate for patients. When healthcare providers interrupt chest compressions, perfusion pressure falls dramatically and remains very low until compressions are resumed. Because coronary perfusion pressure measurements are not readily available during a resuscitation attempt, healthcare providers can monitor CPR quality with waveform capnography and intra-arterial relaxation pressure. We'll discuss the details of waveform capnography in a minute, but an end-tidal CO2 reading of less than 10 millimeters of mercury will not achieve ROSC. For intra-arterial relaxation pressures, a reading of less than 20 millimeters of mercury indicates ineffective compressions. To perform high-quality chest compressions, healthcare providers should push hard and push fast. Push hard means the provider should compress the chest at least 2 inches. This is a change from the previous guidelines, which suggested a compression depth between 1.5 and 2 inches. The chest should completely recoil after each compression. If it does not, coronary perfusion will remain low. Push fast means to deliver at least 100 compressions per minute. Scientific studies show that the rate of chest compressions is directly linked to ROSC and neurologically intact survival. It can be difficult to maintain such a vigorous pace, which is why the American Heart Association recommends that rescuers switch roles after 2 minutes or 5 cycles of 30 compressions and 2 ventilations. Another characteristic of high-quality CPR is minimal interruptions in chest compressions. The American Heart Association cautions providers against spending more than 10 seconds checking for a pulse or assessing the patient. Rescuer fatigue can also impact the quality of compressions. That is why the American Heart Association recommends switching rescuers about every 2 minutes to avoid fatigue. Finally, high-quality CPR must avoid excessive ventilation. For arrest patients, appropriate tidal volumes should be approximately 500 to 600 milliliters, enough to see visible chest rise. This is about half a squeeze of an adult ventilation bag. Excessive ventilation can cause not only gastric inflation and resulting complications, but can also increase intrathoracic pressure, decrease venous return to the heart, and lower cardiac output and chance of survival. In terms of defibrillation, there are no major changes in the guidelines. The emphasis remains on a fluid integration of defibrillation within high-quality CPR. Healthcare providers should start chest compressions and use the AED as soon as possible for the best patient outcomes. The AHA still recommends the one-shock protocol for VF and pulseless VT. Let's review the changes to the BLS survey, which is now made up of these 4 steps. Check the patient for responsiveness. Activate the emergency response system and get an AED. Circulation. Check the carotid pulse. If you cannot detect a pulse within 10 seconds, start chest compressions immediately. Give cycles of 30 chest compressions followed by 2 ventilations. Defibrillation. If indicated, deliver a shock with an AED or defibrillator. Here are the critical concepts for high-quality BLS. Push hard and fast. Allow complete chest recoil after each compression. Minimize interruptions in chest compressions. Switch providers about every 2 minutes to avoid fatigue. Avoid excessive ventilations. BLS is the foundation for ACLS. The better these steps are performed, the better the patient's chance of survival.